All, this is Dr. Mobeen Sayed from drbeen.com. We will continue our discussion about COVID-19 topics. The discussion today is about Lenzilumab. Lenzilumab is a humanized monoclonal antibody. Let's talk about it. There has been a couple of studies where they saw the effectivity and the potency of Lenzilumab in the COVID-19 patients with positive results. So let's start this discussion. So first of all, here is the study. If you see, this is the first clinical use of Lenzilumab to neutralize GM-CSF in patients with severe COVID-19 pneumonia. So our discussion is primarily going to be looking at what is the granulocyte monocyte colony stimulating factor, or GM-CSF, and what is the role of that. So if you see here, let's look at the study first. If you see here, they're saying that we used Lenzilumab, an anti-human GM-CSF monoclonal antibody, to treat patients with severe COVID-19 pneumonia. So they were severely ill patients. Lenzilumab was given in 600 milligram intravenous for 3 doses through an emergency single-use IND application. So they got an emergency use authorization, gave 3 doses of Lenzilumab with 600 milligram per dose intravenous. 12 patients were treated, 12. Clinical improvement was observed in 11 out of 12. 92% of the patients improved, which is excellent. And with a median time to discharge of 5 days. And look at this, there was significant improvement in oxygenation. The proportion of the patients with SpO2 and FiO2 ratio lesser than 350, which is bad, at the end of observation was 8% compared to in the baseline 67%. So there was improvement in oxygenation, which is awesome. A significant improvement in mean CRP, so C-reactive protein. C-reactive protein, we have talked about it before. It is an acute phase protein and is an indicator of the severity of the inflammatory response or cytokine response. So CRP improved. Interleukin 6 levels improved as well. And I'll connect the dot in a second that what is the role of interleukin 6 over here? Or why are we looking at that as well? And then cytokine analysis showed a reduction in inflammatory myeloid cells, and we'll talk about those cells today, 2 days after Lenzilumab treatment. So within the 2 days or 2 days after, the inflammatory cells that could give rise to cytokine storm were reduced. There were no treatment emergent adverse events attributable to Lenzilumab. So they didn't see any side effects. So the conclusion was that this drug is useful and we should do larger studies and so on. So this is one. I also want to show you this case report, and I have put the link in the description. This case report is very interesting as well. So here what they've done is they've taken a patient who was 68 years old, I believe. It is over here. Yes, 68 years old male. He was going into a respiratory deterioration. He was hospitalized, and they have presented the whole case over here. And I would request you to look at it. Look at this one. I really like it. This is the beginning X-ray before the treatment was started. And look at this, how much of the lungs in the basal areas have become damaged or have gotten the pneumonia there. And then as they started the treatment, how the pneumonia went down. And finally here you can see this almost became recovered. And the interesting thing is, in this case report, if you read it, they have given 3 drugs, hydroxychloroquine and tocilizumab and Lenzilumab. And the order was hydroxychloroquine and Lenzilumab first. Patient, excuse me, patient kept deteriorating, and then they offered tocilizumab as well. But the time of Lenzilumab and tocilizumab was so close to each other that it was 5 days between them. that they can't say it was one or the other. However, what they saw in the case was that giving them both actually helped the patient a lot and he recovered. So I wanted to quickly look at this with you. So see here, this is the summary points. They had a patient who was going into the cytokine storm. Tocilizumab, which is an IL-6 receptor, and we have talked about it in the past. They gave that. They gave Lenzilumab, which is a monoclonal IgG1 kappa type antibody, which is against GM-CSF, and we'll talk about it today. With that, they had given hydroxychloroquine, and the patient started recovering, and patient was discharged. So that is a good news here. So that was a case I wanted to talk about. And now let's look at Lenzilumab itself. Look, Lenzilumab is a humanized monoclonal antibody, the class IgG1 kappa. And we have talked about the monoclonal antibodies. These are produced by bacteria or by other transgenic things other than human beings. And this particular antibody, it targets a soluble GM-CSF, granulocyte monocyte colony stimulating factor. It's a chemical substance, and we'll talk about that in detail here. So I'm not going in detail right now. But imagine if this was the GM-CSF, it is a soluble component which is present, which is secreted by various cells, and it is in the blood. From the blood, it goes to bone marrow. Over there, it stimulates the production of many types of cells, including inflammatory cells. So the Lenzilumab is standing here. It has blocked the GM-CSF, which is soluble, and it would not let it go and stimulate the inflammatory cell production from the bone marrow. So with this, let's look at the sources of GM-CSF. Where does the granulocyte monocyte colony stimulating factor comes from? So many of the cells here you are already familiar with, and some are new cells. So let's start from here. We know macrophage. We have been talking about it almost on a daily basis. It would take up a pathogen. It would connect that pathogen to the T lymphocyte, naive T lymphocyte, and provide the initial beginning of the immune responses. So macrophages can release GM-CSF. When the T cells are stimulated, they release GM-CSF as well. Granulocyte monocyte colony stimulating factor. So here, if you can see, this is the naive T cell. This is T helper 2. This is T helper 1. They are able to produce GM-CSF as well. Then the endothelial cells of our blood vessels, they can produce GM-CSF as well. The fibroblast, this guy who is sitting here all looking nice and dandy, this guy, fibroblasts, are the cells present in our connective tissue, and they give rise to fibers. Fibrous tissue is in turn useful for our connective tissue's flexibility. So fibroblasts, when they get injured as well, they can release GM-CSF. And if I come back here, we have briefly talked about natural killer cells in the past. Natural killer cells are like cytotoxic T cells. What their function is that they can connect with a normal cell or an abnormal cell and kill it if the cell is not healthy. So how do they do it? Remember when I talked about it in the past, I made their big hands. Natural killer cells are sort of pervert. They would touch every cell on their way. So what they would do is, if these are normal cells, tissue cells, and there is a natural killer cell that is there, it is going to go around the natural killer cell. It's going to go around, touch every single cell, and see if these cells are healthy. Healthy cells can make their proteins that are displayed on their surfaces. Just like imagine if we have our hair on our head. So hair are produced because our cells are functioning there. So imagine if for some reason the hair are lost and the natural killer cell comes in and kind of tries to see that if the cell has all the proteins that are necessary to show on its surface. If those proteins are not showing, that means that the cell may have become unhealthy. Maybe there is a virus in it, maybe there is a bacteria in it, maybe there's a fungus in it, or maybe there's a cancer in the cell. Keep in mind that in our immune system cannot remove a pathogen that has already gone inside the cell. That is like a thief hiding in a home. And police outside in the street cannot get the thief out. What police would do, our immune police will do, is they would just destroy the whole house. They would just burn it all. So that is the function of the natural killer cell, just like that is a function of the cytotoxic T cell, that when they see that there is a cell that is not healthy, they would kill that cell. So natural killer cells can produce GM-CSF as well. And finally here, this is this guy here. I like and dislike this guy at the same time. This is a mast cell. Mast cells are the cells which are, of course, do some good immune function as well, but they are the one who are responsible for allergic reactions too. And that is why he has a mast here. So mast cells can also produce GM-CSF. So cool so far. If you see here, now you can see in this whole picture, there are so many cells in our immune system that can produce GM-CSF. Very good. So there is a very good comment here from Kent, and that is that interesting fact: for every protein produced in the cell, a related epitope is expressed on the surface of the cell. What that means is that whenever our cells are making any proteins inside of them, so let's say this is a cell, this cell is making something, whatever is needed for its function, those proteins will be presented to the surface as well. So just to expand on this one comment, it is interesting and important. Our cells blindly will present everything on their surface. That may be a virus, that may be a bacteria or a fungus, or the proteins of our own self. It is the duty of the immune cell to not respond to those antigens or those pieces of bits and pieces of proteins that belong to our body. An immune cell would just not respond to them, but those antigens that are presented on the outer surface, which are kind of a pattern that is not part of our body, to which to which then the immune cells will respond. So sometimes the autoimmune diseases, on the other hand, are the situation where our immune cells start responding to these presented antigen which are part of our self, and immune cells just start attacking our cells as well. So a good comment, Kent. Thank you very much. Continuing on. Now, what is the role of GM-CSF? This is the most important slide for today. Granulocyte monocyte colony stimulating factor is a chemical substance that is released by the cells we just talked about. This substance would go to the bone marrows, and in the adults, the bone marrow that produces blood cells are usually the flat type bone marrows, for example, vertebral bodies, sternum, hip bones, upper part of humerus, and upper part of femur. They are not flat bones per se, but these are the kind of bones that produce the blood cells. So GM-CSF goes into the bone marrow. In the bone marrow, if you start from here, if you start from this side, in the bone marrow, there are stem cells. And the quality of the stem cells is that whenever they make other cells, they can make their own type as well. This is by definition a stem cell. If we could produce children that look different from us, but if we could produce offsprings that are exact clones, then we will be called stem human beings. So stem cells are those cells that can produce their exact type, plus they can produce other types as well. So here is a stem cell. This stem cell is called pluripotent stem cell. Pluripotent stem cell means that pluri means many, potent means capabilities, stem cell is stem cell. So this is a stem cell that can give rise to other cells of all kinds, many capabilities this cell has. That means it can produce cells of all types. So this is, you can say, the grandparent cell. It would allow all other cells to be formed. So here, the two main categories of cells that are produced are called myeloid type and lymphoid type. If you see here, lymphoid is more, we are more familiar with lymphoid nowadays because of immune discussions. So lymphoid progenitors, or the lymphoid parent cells, give rise to three kinds of lymph cells. These are T cells. We talk about them all the time. We know that T cell in turn are of T helper type, T cytotoxic type, regulatory type, and 17 type. But these are the T cell. Then these lymphoid progenitors or parents also can give rise to B cells. These are the cells that make antibodies. And then they also give rise to natural killer cell. Now, here is an interesting thing to note. Natural killer cells are actually lymphocytes. And lymphocytes are part of the acquired arm of the immune system. Sorry, yes, acquired arm or adaptive arm. However, natural killer cells break rank with their fellows, and they go and join the innate army, the innate arm, and they become part of the first responders. So they are the only lymphocytes that are not part of the adaptive arm. They are created as part of adaptive arm, but they would then break ranks and go to the innate arm and work with them. So these are the lymphoid progenitors. Similarly, we also have myeloid progenitors that give rise to all other kind of blood and immune cells. So let's look at those cells quickly and note the GM-CSF's presence. This substance is, and this is all happening in the bone marrow. And these substances, for example, to make a red blood cell here, we need interleukin-3 and GM-CSF. And that would allow the myeloid progenitor cell to break into further children and make red blood cell, or divide into daughter cells and make red blood cells. Similarly, the myeloid progenitor cell, in the presence of interleukin-3, interleukin-6, and GM-CSF, will become megakaryocyte or give rise to megakaryocyte, which will then make platelets. And we have talked about platelets as well, which are the cells that help with the clotting. Then myeloid progenitor cell give rise to granulocyte, and this is what is important for today. If you see here, in the presence of interleukin-3, interleukin-12, and GM-CSF, the myeloid progenitor cell gives rise to a daughter cell that is called colony-forming unit, granulocyte monocyte. This cell, in turn, gives rise to these guys. And if I can look at these top three, these are called granulocytes. And why are they called granulocyte? When you look at them under a microscope, they seem like they have little granules in their cytoplasm. And they take on various colors. So over here, for example, there is neutrophil. Neutrophil do not have a color in them, but they do show these granules, and their nucleus are multilobed. So that, imagine now again here, GM-CSF is needed. Neutrophil is a very important cell of the innate arm of the immune system. Then if you see here basophil, again, they have those stipulations in their cytoplasm, and they are produced by interleukin-3 and CSF. Then if you look at eosinophils, eosinophils are very important cells, and they fight usually the worms. Plus they can also participate, or they are implicated in the eosinophilic asthma, which is called atopic, non-atopic asthma. So anyways, they are active in asthma as well. Plus most of the parasites, the worms that are in our body, if they are in our body, eosinophils are the ones that fight with the worms. And if you see here, they need GM-CSF as well. They, of course, need interleukin-5 too. And then monocyte here. Monocytes are not granulated. They have a non-granular cytoplasm, but they also need GM-CSF to be present to be produced in the bone marrow. With that, they also have MCSF, which is monocyte colony stimulating factor. So in the presence of these factors, monocytes are produced, which, do you know what monocytes are the parents of? Monocyte, when they are produced, you would actually like this one. Monocyte go into the blood vessels from the bone when they are produced there. So when they are circulating in the blood vessels, we call them monocyte. Then they come out of the blood vessel in various tissues and they live there forever. They become residents there. These resident monocytes are macrophages. They are macrophages. So what is a macrophage? A macrophage is actually a monocyte that has left the blood vessel, that has left the blood system and moved out and has started living in some tissue. And that tissue can be under the skin. They live everywhere. They live in our lungs. They live in our spleen. They live in our heart. They live in our muscles. They live in all the connective tissues. Similarly, monocyte can also become dendritic cells. That is also the cell that is part of the innate arm. And monocyte can become other kind of cells too. So this is really important to see that the important cells of the innate arm are actually resident monocytes. And that is what we are talking about here. And again, we need GM-CSF for that. So that means when GM-CSF is present, majority of the immune system cell numbers will increase in our body. That then in turn will cause a larger number of cells producing a larger number of cytokines, producing a larger number of inflammation, will cause cytokine storm, and that is what can cause the severe disease, even up to death. So now this drug that we're talking about, Lenzilumab, it actually blocks the GM-CSF. So imagine, look at this diagram. If you block the GM-CSF, almost all areas of the cell production will reduce. Here is RBC. Here is the platelets, GM-CSF for the granulocyte monocyte. This area, all of them would reduce, especially the monocyte, which will then give rise to the macrophage. Then eosinophils are down, basophils are down, neutrophils are down. Neutrophils are also part of the innate arm. And these guys, natural killer cells and others, they do not have GM-CSF that is important for them. These cells in turn produce a lot of interleukin-6. That interleukin-6 then will cause the liver to produce acute phase proteins, plus interleukin-6 produced from here, interleukin-6 will go and amplify the immune system once again. And we have seen the drug for interleukin-6, that is tocilizumab. And the case report I just showed you, they were using tocilizumab, which is for the interleukin-6 blockade, and then the drug that Lenzilumab that we're talking about, that is on this area. So when given together, tocilizumab and Lenzilumab, they can actually be very powerful, because not only they would reduce the production of these cells, they would also reduce their further amplification by blocking the IL-6. Now continuing on for the Lenzilumab and COVID-19. Check here. This is a CD4 cell. The helper T cells are called CD4. The cells that are cytotoxic T cells, or the ones that kill the other cells or effector cells, these are called CD8. CD4 and CD8 cell produce GM-CSF. Similarly, in the bone, osteoclasts can produce interleukin-6. Then macrophages produce interleukin-6. Then endothelial cell smooth muscles produce interleukin-6. And it is observed that the plasma, so this is a patient's blood, we have centrifuged it, and this area is the red blood cells, this area is the lymphocytes, and this area is their plasma. The plasma of the patient, in that study I'm now talking about, they said that, hey, in the plasma of the patient, there is significant, those patients who are in the ICU, there is a significant elevation of all of these interleukins. And if you notice here, there is GM-CSF in here. And when GM-CSF is present, it causes other cells to become active, which then have other interleukins that become active as well, including interleukin 6. And that is how the immune system just keeps amplifying itself, forgets about the virus. It just is amplifying and just going. It is all wound up now, and it is causing local damage blindly without any reason. So in the study, they said that, look, these are more in the ICU patient and they are less in the non-ICU patient. So there is definitely some problem going on here. And if we somehow can block these things, then we can help the patient. So here, this is a study I just mentioned in the beginning as well. They did this study where there were 12 patients who were severely ill. They treated them with Lenzilumab. 11 patients improved. 5 days median time to discharge. That is an excellent thing. Oxygenation improved. CRP levels, interleukin levels 6 improved. And then here, inflammatory myeloid cells, the cells that we just looked at here, these cells, and these cells. They said within 2 days, inflammatory myeloid cells started reducing. So that is the discussion. This drug, we just talked about the dosage. They used 600 milligram thrice intravenous. The results are excellent. We also saw a case report where this drug is used with tocilizumab as well, with great results for a patient who had comorbidities. If you look at their case report, patient had, I believe, hypertension as well, plus they were smoker as well, plus they have some more comorbidities as well. Age was 68 years. The patient was deteriorating fast. And even then, with hydroxychloroquine, tocilizumab, and Lenzilumab, patient recovered. That is an excellent news. So this is the discussion for today. Tomorrow, I'm going to talk about interferon beta as well, which is a new study as well on interferon and how that would help the patient. I hope that that is good. If you have any other topic to discuss, we can talk about that as well. There is a question on gene patent that what is the half-life? So I know that tocilizumab's half-life is, I think, 16 days. I'm not sure about the Lenzilumab's half-life. I'll have to look it up and I'll put that in the comments. So with this, how is everybody doing? Are you keeping safe, healthy? Are you taking your supplements? Everyone good? So we will stop after this. Please do me a favor. Please like, subscribe, and share. Stay safe. We'll see each other tomorrow. Bye-bye for now.